Good morning, everyone. I'm very much obliged to the organizing team, Madhuri Chandra ma'am, and the rest of the team to give me an opportunity to speak at this session. And I feel greatly humbled after talking after the guru and my mentor and my ideal, Dr. Amita Maheshwari. It is, I am just one, maybe just a drop in front of her, but it's my, it's my privilege, and I feel really humbled. So the topic given to me today was endometrial malignancy. What are the preventive and diagnostic tools which we can adopt for this? Um, I have no disclosures to make. I have made it from the multiple guidelines and the studies. So coming to the endometrial cancer, approximately 95% of uterine cancers are endometrial and endometrioid cancers. That's why endometrial cancer and uterine cancers are often used interchangeably. Um, we see in this graph that the incidence of endometrial cancer is much higher in the perimenopausal and menopausal women. It may be a hysterectomy in the adjusted endometrial cancer or an endometrial cancer, but why we need to know uh, the about the endometrial cancer is because it is an cancer which is in the aged perimenopausal and the menopausal group. We also see, as has been told in the previous cancers also, that the epidemiology clearly shows that there has been an increased incidence of endometrial cancer because of the various reasons. And as it is projected, it is going to go up and up through the years if we don't take care of it. Coming to the cancer itself, we know that endometrium is formed of two main components, the endometrial glands and endometrial stroma. And the malignant tumors of the endometrium, uh, those that are arising from endometrial gland are the endometrial carcinoma and the carcinosarcoma. And those from glands as well as stroma are the adenosarcoma, and those from endometrial stroma are the endometrial stromal sarcomas. They are again broadly classified into type 1 and type 2, and the type 1s are the endometrioid, which mimic the proliferative endometrial glands and are the most common. 85% of them are the endometrioid cancers, and the type 2, which occur at a later age, are the serous types. The recent type of cancer, the recent advances that have been into the classification are the molecular subtypes, and apart from the endometrioid and serous, they are also classified into the mutations in the DNA polymerase, which are the ultramutated or the pol type, or hypermutated MSI mutations in epigenetic signaling, or of the mismatch repair gene. And they may be copy number low or copy number high. The copy number low MSS tumors, which are mutations that upregulate the signaling through the P13K and AKT pathway, and copy number high, which are the serous-like tumors often associated with the TP53 mutations. Now, these are the, in the hallmark of the endometrial carcinoma, there is increased signaling through the P13K and AKT pathway, and these compose of the most of the mutations. And they increase the expression of the ER-dependent target genes in the endometrial cells. Now, the various genes involved are the P10 tumor suppressor gene, PIK3CA mutations, the KRAS, and the ARID1A. Now, one good news, these are the genes that are tested in the samples, in the hysterectomy samples or the endometrial samples by the immunohistochemistry. And it is a good, the good news is that the pole gene mutations are having good prognosis than the other genes that are there. Now coming to the endometrioid carcinoma, what we are looking here is the preventive aspect. We need to study what can we do in order to prevent the endometrial carcinoma. So the most common is the endometrioid carcinoma, which has a very high unopposed estrogen stimulation. The main symptoms, why is it important, why it is easy to for us. Now, the endometrial carcinoma presents very early because it has the symptoms which can be caught early at an early stage. So the main symptoms which we encounter in the uterine cancer are the abdominal vaginal bleeding. There may be vaginal discharge. There may be pelvic pain, painful urination, pain during intercourse, or unintentional weight loss. So coming to the prevention, what we can do. Now, in order to prevent the cancer, uterine cancer, we need to look at the risk factors, which are mainly various risk factors we need to identify in the group of the women which we are dealing with. Coming to the age, usually the uterine cancers are present in the perimenopausal and the menopausal age group. So we need to keep in mind that any women presenting with the symptoms that are there, we should be able to screen them and then proceed for further, because the other risk factor include the hormonal imbalance, the obesity, menstrual problems, the family history, and various ovarian disease, early pelvic radiation therapy, and tamoxifen use. All these can cause endometrial hyperplasia, and the main aim to prevent these cancers is the prevention of endometrial hyperplasia. Now, endometrial hyperplasia, as we know, can be easily prevented by balancing the hormone levels, which especially in those patients who have unopposed estrogen exposure, they can be screened and they can be tested, and they have to be treated in time. Also maintaining, because obesity and the conditions like polycystic ovarian syndrome, they are also one of the main risk factors which are involved in the pathogenesis of the endometrial hyperplasia, thereby increasing the incidence of endometrial cancer. So maintaining a healthy lifestyle and maintaining and managing and treating the conditions like polycystic ovarian disease is a important is an important aspect. The key strategies in these, they include using progestrogens for various menopausal hormone therapies. Also, progesterone in the cases of polycystic ovarian disease where they have menstrual irregularities, and those who present with for infertility, and we diagnose them early and we can prevent that. Also, regular exercise, adopting a healthy diet, and considering hormonal contraceptive to regulate cycles is a good option for preventing the endometrial hyperplasia. The risk factors that are to be managed in these patients are the irregular menstrual cycles, which are often seen as in polycystic ovarian disease. Then keeping in mind that those patients who are on medication, for example, tamoxifen, which is used for breast cancer, these should be monitored closely and periodically so as to keep an vigilance on these patients so that they don't develop the endometrial carcinoma. Now, smoking is also one of the risk factors that has been inculcated as a risk factor for the endometrial cancer. And the counseling can be done and for the lifestyle modification, especially in those patients who are vulnerable to develop the endometrial carcinoma, especially if they have other risk factors also. In the patients who have unopposed estrogen stimulation, patients fibroid, or those that we, especially those taking unopposed estrogen therapy for menopause, they should be added progesterone therapy in between in order to reduce the risk. The weight management, as we have discussed, is important, and also the hormonal control. The other prevention studies can be dietary choices, which we have a full session on the nutrition of the in the menopause ladies. We can see that we keep a diet which is low in sugar and high glycemic load. Foods can actually help prevent high insulin levels, which are linked to the conditions. Then regular checkups such as routine pelvic examination and endometrial biopsies, if advised, can help in early detection. Coming to the various diagnostic tools, we have different diagnostic tools which are there. Apart from the good medical history and physical examination, the various blood tests that can be used to assess the overall health and to check the specific markers may be useful and can point to the other cancers. But basically, CA125 as such is not a marker for endometrial cancer. So in case if it is high, then we might look for other cancers if it is needed. The imaging studies are the ones that are the mainstay of diagnosing this, and they can be usually the most used and the non-invasive one is the transvaginal ultrasound, which is gaining, which is to be used for the screening purposes. The other imaging studies can be in the form of CT scans. So what are the advances that are occurring in the transvaginal sonography? Apart from the endometrial thickness, there are other features which are being combined these days to enhance the sensitivity of the transvaginal sonography as a diagnostic tool. In type 1, which is the endometrial cancer, the thickness of more than 4 to 5 millimeter in post-menopausal women with bleeding can substantially increase the risk of the malignancy. In type 2 endometrial cancers, even a endometrial thickness of less than 3 millimeters may be found, and hence Dopplers may be combined to increase the sensitivity. The value of three-dimensional scanning is of use here. The high-end scanners are useful in scanning the Doppler changes and also at the endomyometrial interface, and are sensitive to detect the Doppler signals and the blood flow. The endomyometrial interface vascular blood flow can be picked up for the changes in new angiogenic processes which occur in the endometrial cancer in the tumor and also in the near surrounding areas. The three-dimensional sonography can be also used because apart from the endometrial thickness, it is also important to note the various other features such as the mixed echogenicity or the hyperechogenicity, the high color store, and multiple globally entering vessels which are seen in the lesion. There is a concept of risk of endometrial cancer scoring, and this is usually used to improve the sensitivity. So the other tests that are used are the endometrial biopsy, dilatation and curettage, and hysteroscopy. And endometrial biopsy is an outdoor procedure which can provide a definitive diagnosis. Dilatation and curettage is another test which is more sensitive because it gives us an elaborative material insight into the disease, and the various histopathological things can and various histopathological pictures can help us diagnose the benign from malignant disease. The other modality used is the hysteroscopy. It is again an endoscope which is used to visualize the endometrial cavity, and the direct visualization is better. And they have been able to devise various morphological features in the hysteroscopy which are suggestive of the endometrial hyperplasia as well as the cancer. And it is important that when we do the hysteroscopy, the negative hysteroscopic view indicates the likelihood of the normal uterine cavity, and in these patients the sampling is not necessary. So the take-home message is that endometrial cancer definitely is a cancer of the perimenopausal age group, and it should be sensitively approached with any women who is coming with the bleeding or any symptoms should be investigated. The early diagnosis is very much possible, and if detected, it has a very good survival chance. Awareness about the risk factors and their prevention or management can be useful, and the precision approach towards the diagnosis of the category is also helpful in planning treatment. Thank you so much.
Thank you, Dr. Amrit Arora Didi, for a nice elaborative and overview of the endometrial carcinoma. Yes, I think some specific point which you stressed is that in screening, we should always go for Doppler study of endometrium. So this is going to help us a lot in diagnosing the case.
I just want to ask one thing, whether the increased size of uterus in a postmenopausal woman should be screened more.
Yes.
So
definitely.
when we do a screening sonography, then the size of uterus, if it is more than 8 or it is more than 7,
the multifarious size is
then
usually
there are more
common,
chances that she
but
is.
then even the endometrial hyperplasia is very common. And
even if her endometrial thickness is very low, still if the size is more, then we should definitely go for the...
Because most of the cancers are endometrioid, and endometrioid are precursors from endometriosis and adenomyosis. So we should be like endometrial hyperplasia especially. So endometrioid tumors can be from the endometrioid or the endometriosis, because we had few patients who had endometrioid ovarian cancer and then they developed endometrioid uterine cancer.
So size of uterus matters.
Size of uterus does.
There is no study the size of uterus will affect the cancer.
Yes, because
No,
it could
the chances of...
Endometrial thickness is having a correlation.
No, but chances of cancer are more in a patient who has increased size of uterus.
there is no such study,
Yes.
because increase in the size of the uterus can be because of fibroid, it can be because of adenomyosis, but it is not.
So we will have such question answers in lunchtime, as
Means
we are
if you
already
see
getting late.
otherwise, because fibroid itself is in women who have estrogen predominant milieu. And also adenomyosis, as we see, it is associated more with endometriosis. So means there can be an indirect correlation, but yes, we need to investigate to see that it is.
Thank you, Dr. Amrit Didi, for such a nice presentation. Thank you.
Thank you.